Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm really pleased to say that I'm joined by the chair of the BMA England GP committee, Dr Katie Bramall, to talk about the new GP contract and what happens now with the ongoing dispute with the government. In this conversation, Katie explains why she thinks the 2026-27 GP contract is a bad deal for general practice and some of the problems around same-day access, advice and guidance and practice funding. She talks about what happens if GPs reject the deal in the BMA's referendum, which launched on Wednesday this week, which may mean the profession is taking action from as early as the 1st of April and raise the prospect of more serious action that could put practices in breach of their contract later in the summer if there's no movement from the government on the contract. We also discuss the government's plans for a neighbourhood NHS and how this will affect general practice, and Katie explains some new BMA guidance on what practices and GPs should be doing now.
Hi, I'm Pat Anderson, editor of MIMS Learning, and I'd love to introduce our virtual event, MIMS Learning Live Digital. This takes place over 4 evenings from Monday 9th to Thursday 12th of March, starting at 7 p.m. each night. By attending, you can gain CPD hours and learning to help you support your patients. Our chair is GP Dr Pipin Singh, and our speakers include Professor Raj Thakkar, talking about cardiovascular disease and frailty, and consultant Dr Helen Pears, who will provide tips on management of ADHD in adults. Join me for this fantastic clinical learning event. You can register for free via the link in the show notes.
I'm delighted to be joined on the podcast now by someone who really needs no introduction. It's the chair of the BMA England GP committee, Dr Katie Bramall. Thank you for coming on the podcast, Katie.
Oh, thank you so much for having me, Emma.
Obviously, very busy time, lots going on. New GP contracts just come out for 2026-27. Now, you met as a committee last week and you rejected the contract for England. So why is it a bad deal for general practice in your view?
In a nutshell, this contract is imposing unrealistic and unsafe changes to the practice contract. You look at it and you think, is this a GP practice contract, or is this just some sort of ruse to protect emergency departments and 111 and try and mitigate corridor care and try and manage elective waiting lists and protect hospitals as much as we can? Or is this what we've been told around the shift from hospital to community and the shift from sickness to prevention and the shift from analogue to digital? What the government is saying and what they're doing, it feels like it's two different things. And a lot of GPs have said to me, it feels very gaslighty. And I feel that too, because there's really warm words coming out of government to me and to my BMA colleagues, getting round the table for a new contract. And yet you're like, well, when? Because it's almost a year ago that we got that written promise from Wes Streeting. And 12 months on, we really are no further forward. And time's running out. And in that time, how many hundreds of practices are now gone? How many experienced partners have now walked away? The number of unemployed GPs is a massive issue. And you might look at that as being a less bad part of this contract, but it all has some really existential problems attached to it. If you take the advice and guidance contractualisation, put that alongside the medium-term planning frameworks, clear articulation of what they want to do around advice and refer, that is an absolute recipe for total destruction of general practice. If you remove the right to refer, you uncap and enforce contractually all urgent care and all non-urgent care, we can't bend the laws of physics. We are not magicians. And all for the sake of some populist sound bites to try and get some voters, when actually the million-plus population that use our services every day are going to see there's no more rooms, there's no more appointments, practices are incredibly stressed, they're going to hit absolute overwhelm, and that needs to be understood in the same way that we get these emails from local trusts when ambulances are on divert, please don't send your patients in, as if we do it for the fun of it. It feels staggeringly badly managed in terms of what is really going on here right now. And it tells us a lot about where the true priorities are sitting. And you can't help but feel this is, as it ever was, this David and Goliath between general practice and these huge multi-billion-pound acutes that are seen as too big to fail.
In terms of the same day access, it sounds like you think that that's going to be a problem. So this is same day access for urgent patients, and practices can determine who they believe is urgent. Now, there was an NHS England webinar this week where they were saying that most practices are doing this anyway, so it shouldn't be a change. So why do you think that particular issue is a problem?
Two things. Firstly, we're going to need to see what the draft regulations say.
Yeah.
Because comforting words on a webinar and hard black and white type in legislation are two different things. We were told a year ago, of course we will work together in good faith to secure safeguards around online consultations, but actually what really happened in reality and what did the regulations say? And secondly, there's the juxtaposition of what you're promising to the public in repeated PR campaigns and then what you're saying to the GP workforce as in, oh, don't worry, you'll do it anyway. It feels to me a little bit of deja vu in how it was in Tony Blair's government with the whole 48-hour access thing. And we're probably going to be given a SNOMED code that we're expected to enter with every single same-day appointment just for the sake of it, to tick a political box. We know there's so much GP appointment data that NHS England holds. They've got all the wealth of evidence they need. You ask yourself, to what end? It's a little bit like an additional tick box that they want to discuss choice of pharmacy prior to a new electronic prescription being issued. Even if that takes 2 seconds, look and see how many new prescriptions are issued every day and how many hundreds of thousands of hours of GP time this is that is not being appropriately valued. And it's around truth and honesty and how that's framed with the public. Because if you keep promising the world to the general public, yet their experience is that emergency departments are smaller, the numbers of beds have never been fewer, and the population has never been greater, then there's this immense disconnect between what's being promised and what's being experienced in reality by the workforce every day and by patients who desperately need these services. And all we want, all this is actually around, is getting around the table in good faith to negotiate a new contract that's going to value partnerships as part of the communities that they're in, that's going to provide fair remuneration to all GPs, and will provide those workload safeguards that are so important, not just for GPs, but for our practice teams and for our patients. That's what it actually all comes down to. So why is that so hard? That's the real burning question.
Talking about the money, overall, do you expect practices to be better or worse off once this sort of contract beds in over the next financial year?
I think they're going to be worse off.
Right.
In terms of a lot of the financial modelling, there's data that we don't yet have that's going to be crucial to being able to understand it and model it. Now, I've seen stuff online. There's one blogger called Richard Hennessy that's been shared a lot over the weekend and on the X platform. There's lots of problems with some of his assumptions, but I still don't believe this is going to leave practices better off. I believe the patient experience is going to be worse because there's nothing here that's going to be genuinely supporting continuity of care. We don't yet know what the DDRB conclusion is going to be. Now, the government has got a 2.5% uplift assumption, but we've seen Agenda for Change and the nursing unions agree 3.3%. Will it be around that figure? Will it be slightly higher, slightly lower? We just don't know. Now, I suppose the one improvement is that I think the expectation is not that DDRB is going to lag into July so that we start to then get the payroll coming through in November. I think the plan from the new DDRB board is to actually feed back to the government by the end of this month so that they can get the wheels moving and people are aware of their financial forecasting in April at the earliest and May at the latest. There's a lot of things that cause massive problems for me. There's so much that's not yet understood around how the funding flows will work. I can't say practices will be better off because it'll absolutely depend upon the practice and the population and how they work and what they do, how they're able to potentially access the funds for GP reimbursements, how those GP reimbursements will apply. So many things are unknown at this stage.
Do you think the DDRB will recommend an uplift over 2.5%?
I'd be surprised if they don't, but I'm just very conscious of that Agenda for Change, and I think it could be quite hard for them to suggest any less than that. But they're very keen to make the case that they are genuinely independent They're a brand newly appointed board this year, the DDRB. There might be more of an inclination to demonstrate how independent they are. The oral evidence that I attended early in December went on much longer. The questions were much more detailed, especially around underemployment of GPs and especially around registrars and trainers, and much greater specific detail they were after, which I found really reassuring that they'd gone into a lot of the detail and around expenses mechanisms in GMS and how it doesn't work. That was also quite encouraging, that they really had a very good grasp of the issues. But whether or not that's me being too optimistic, we'll have to wait and see. I'd be very disappointed. I would hope it's going to be north of that. But still, that's nowhere near where we need to be.
You mentioned that practice level reimbursement scheme for recruiting GPs. Now, this is something that the BMA GP committee have been calling on for a while, and it's materialised, but perhaps not in the way you would have hoped, because the way they're going to fund this is through the removal of the capacity and access payment that PCNs currently receive. And it seems to me that this is likely to be really problematic, and this is what's going to cause practices a lot of issues around their finances. What are GPs telling you about this, and where do you see the problems coming from this?
I think it depends how a PCN has historically utilised those funds. A lot of PCNs have actually consolidated into let's make things work pragmatically at a practice level, and they've remembered that the whole raison d'etre of PCNs was to support those constituent practices. It wasn't supposed to be another circus to try and have another level of industry and NHS England targets. Our policy within the BMA, within GPC, has always been to move money from the PCN DES into core practice contract funding. But I can see why you'll have some clinical directors who won't like this, because it will depend on how they have been using that money. Is that money just coming in as profit that's going into profit, or is it actually purchasing services or staff? Now, if it's purchasing services or staff, then that's obviously going to have a knock-on impact in how do those staff continue to function. However, if you're going to invest in staff at a PCN level, the evidence would also suggest you're much better off investing in a GP. So anything we can do to eradicate GP underemployment and to take a big burden of cost, including, on costs of employers and national insurance contributions and superannuation, is really important. But there's got to be flexibility, because it's absolutely essential that we increase our numbers of GPs. But if you're in an area, maybe it's particularly rural or coastal, you have a smaller or more disparate VTS, you've got to have that ability to either increase the numbers of sessions that you already provide, or look to see what GPs locally might wish to return, for example, or to flexibly increase their sessions rather than bringing on new people if there are no substantive additional GPs that are able to move into that particular area. But I would hope that we do start to see more and more GPs, because I think that puts greater pressure on the argument for increasing and renovating and investing in our premises, our estates and our infrastructure. It shows the value of seeing a GP, because we've seen the numbers of consultations absolutely skyrocket, and yet patient satisfaction isn't really changing. And we're all familiar of patients seeing multiple members of the wider primary care team, and how often do we think, do you know what, if they'd just seen a GP from the start, how much simpler would this patient's journey have been? There's something here around the need to readjust staffing structures for some PCNs, and I can see that's going to be a nightmare. A lot of it comes down to how networks and member constituent practices have actually utilised their capacity access payments or capacity and investment plan monies historically, and that will very much mean horses for courses. But there is something here, preserving at least some of the PCN DES funding for general practice and bringing it into the national core contract funding pot means the risk of losing that funding to neighbourhood teams is much less. And the neighbourhood teams we cannot assume are going to be at-scale GP organisations. We know that in many areas, you've got quite voracious trusts who would very much be seeking to deploy and take those funds and recruit their own GPs and set up their own alternatives to primary care. And the government, as we know from the 10-year plan, is open to those conversations. So there's something about locking things down and consolidating that funding. And I personally think this wouldn't have happened unless the primary care contracting team at NHS England wasn't spooked by the prospect of the neighbourhood team at NHS England taking those funds and repatriating them elsewhere.
The NHS England letter made it sound like there'll be a new contractual requirement around GPs having to use advice and guidance. In that webinar I mentioned earlier, NHS England said that GPs would be expected to use what they termed locally agreed referral pathways, which would have to be agreed with general practice, presumably, I guess, with LMCs. But will that really happen? Or are you worried that this is just going to lead to a huge shift in work from hospitals to general practice that isn't properly funded?
I'm really worried, because why isn't this in the contract? Why wasn't this put in greater detail? Why is it being left to local determination across the 22 clusters and 42 ICBs? Penny Dash, as chair of the NHS England board, asked Mark Cubban, who's the chief exec of Manchester Foundation Trust, and he's the national director of elective transformation. She said, are there going to be plans to mandate the use of advice and guidance as a requirement for referrals before April 27? And requested details on the intended scope, the timeline, the guiding principles of any mandate. Mark Cubban said, there's been a 24% increase with advice and guidance in the past year. Now, of course, if you contractualise that, and it's not that payment for service, then the numbers are going to plummet. And I think practices are going to send referrals because they explicitly want a referral. But it equally shows that people weren't gaming it, as was alleged could be a risk. The other thing that really panics me is that the enhanced service of advice and guidance in 25-26, you'll recall, was a pilot to repatriate monies from acutes into the GP contract. This isn't. This has been put into global sum of 80 million recurrently, with an additional 2 million uplift for this year. So by contractualising it, they're not trying to build on that pilot of taking money from the acutes. Mark Cubban continued and said that they were engaging broadly with the colleges and clinical operational leads in different organisations and different parts of the system to inform their next steps and part of their wider outpatient transformation. This is a cornerstone of it. It's in our medium-term planning framework. We're going to ask every acute trust in the country to work with their ICB and their local GPs to look at the top 10 specialties where they think it's going to have the greatest impact for advice and guidance. And that's exactly what's happening now, but there's no consistency of approach. And there is still this top-down mandate, but because it's not an explicit guidance, it's not contractualised, but still all 22 ICBs and acute trusts are doing it. So it's through the back door. And my worry is when, as a GP, you have a very clear need for a referral, you've hit the top of what you can possibly do in the general practice space. You now need to be able to access secondary care. If they simply send it back and reject it with a list of diagnostics or further assessments or further titrations and so on, how does that sit against Jess's rule, where the Secretary of State spoke very positively about the need and the importance of, if you have to go back 3 times, then you deserve your specialist opinion. So again, it's that disconnect between what you're promising the public and then what you're contracting us to do. Also, where does it sit within the GMC's duties of a doctor and good medical practice around appreciating when you've hit the limits of what you're able to do and your duty to be able to get the expert care for the patient and making them, the care of them, your first concern? So it feels the left hand isn't talking to the right hand. I'm really anxious about what this means, because I think this existentially risks removing the right to refer by the back door. Now, if you speak to NHS England's primary care contracting team, they'll go, no, it's not going to take away the right to refer. But I think those of us who are experiencing this in practice feel very differently. And you can easily imagine pressure on consultant colleagues to only permit a certain proportion for their specialty per month that then hits their budget limits. This is rationing, but we are left with the consequences, and it feels desperately unsafe.
Rejected referrals are a major issue. So I was talking to a GP the other day who works in practice Monday, Tuesday, Wednesday and doesn't work in practice Thursday, Friday. And they were telling me they dread coming in on a Monday morning because they know what they're going to get. It's just like piles and piles of rejected referrals that they've got to sort out from those 2 days they've not been in the surgery. And that's when there supposedly are locally agreed pathways already. If that's what's going on now, it's hard to see how it's not going to get worse under this new way of doing things.
I completely agree. It puts more power in the hands of the acutes, and they believe a really efficient way of mitigating their elective waiting lists and recovery is going to be mitigating what gets added to that waiting list and at the same time rationalising what's on it. So a lot of our patients are receiving those patient-initiated follow-up letters. When I was in surgery yesterday, it was really rare to sit, maybe once or twice throughout the day, there was something that was actually new that I could manage. Everything was on the workload shift and the leftward shift from the acutes, pushing things back with no safe resource for us to be able to even try and start managing it. And I think this is what is breaking us. This is what's creating the moral injury at large. And I think when you then add little bits on like straws on the camel's back, that's when, if you have the advice and guidance, advice and refer, as well as the uncapped urgent on the day, as well as the trinity of access, all these things just make it feel impossible. And when it feels impossible and when it feels unsafe, that's when people start to feel the need to check out because they just don't feel they can do it. It's a complete anathema to all of their training, and we were not equipped to be doctors in this sort of war zone, which is the NHS right now.
So what happens now? The BMA GP committee have said there's going to be a referendum of the profession on the deal. How's that going to work and what are you going to be asking GPs?
So if you think back 2 years ago when we had a derisory contract offer, and this year it's a really strategically flawed contract offer. But not only that, it's also been a group consultation. It's not been a negotiation in good faith. And that's despite there being almost 12 months of Wes Streeting saying in writing, let's get round the table, let's negotiate in good faith a new substantive contract from within this Parliament. That's literally what I've been elected to do. And instead, I've been sucked into being let down and had my time wasted and seen the fallout of the wrecking ball approach to the profession over the past 6 months especially. And so this is a breather for the profession. It's to say, look, you have an opportunity for all of us to galvanise because this doesn't work for partners, but it also does not work for salaried GPs. It will not provide additional work for locums. And if you're a registrar, this is not going to want to keep you in practice in the NHS. This unites all of us. You each have the autonomy to tell the government exactly what you think. It's not just us as your elected negotiators. We need to show we've got a united, galvanised front because unfortunately with this government it would appear that you've got to force that unity and force the threat of action to be able to get anywhere. Now, any expert negotiator will tell you it's really important to have the creative ambiguity, to be able to move forward, to be flexible, to not be dogmatic around action or timelines, and to see what's the art of the possible. But unfortunately, if you've got a negotiating partner who is taking all of these steps to diminish your voice and your agency and your autonomy, this is all we're left with. So it's vitally important that any of your listeners who are BMA members, when they receive their email from Civica, and it opens on Wednesday the 4th of March at 12 noon, and it closes on Wednesday the 25th of March at 12 noon, that you vote no. No, this contract does nothing to support or sustain general practice or my career as an individual GP or my future career as a GP. And you have got to get back around the table. You have got to negotiate in good faith and secure a contract that's going to help sustain and thrive GP partnerships in our communities, that's going to provide fair remuneration for all GPs and is going to secure workload safeguards, not just for GPs, but also our whole practice teams and our patients as well, because this is desperately unsafe. Now, if the profession decides to vote with its feet and we have an overwhelming mandate to reject the contract, well then the next step is moving to action, and we don't need to take any further steps in between. We don't need to do a further non-statutory ballot like we did in July 2024. We can go straight into action. So it's highly likely that if the referendum has no confidence in the contract or the government, that we would move to action on the 1st of April.
And what kind of action will we be talking about this time? Obviously, that's the big question, because it seems quite likely the profession will reject the deal. So last time practices took collective action in 2024, it was all actions that wouldn't put them in breach of contract. At the LMC's England conference last year, there were votes in favour of taking more extreme actions, even at that time, that could put practices in breach of contract. Are we heading towards that this time, or are we still talking about the kinds of collective action you were proposing in 2024?
Things have moved on because the 2024 menu of actions was predicated on the contract at that time, and loads of those things have now changed, so it has to be completely different. It's essential to remember that ultimately action is a means to an end. And what's the end? It's getting round the table with government. So if government meet us in the next couple of weeks and we define scope and we define a timeline and we start to make traction, well then, great, let's have that conversation. We have got to explore all available options. Nothing is off the table. But we don't need that separate vote to direct non-contract breach collective actions. Now, if we were going to determine a breach action, we would take a vote. And ultimately, it's going to be our members who are going to determine those next steps. I am not going to rule out future actions that will involve and invoke a breach, because for the majority of practices, the feedback is, let us do something uniform around the trinity of access of all routes from 8 till 6:30 and around the urgent and uncapped limitation, because I think that is a real big red flag to practices. They want to feel more safe, and it feels completely unreasonable. So actually, I think the government are making it quite easy for practices to want to breach. But ultimately, we won't start with a breach action, but we're also going to markedly simplify it. It's not going to be a menu. It's going to be one action. That's it. Just do that. Nice and simple, with really clear guidelines, and LMCs are going to be reaching out to all of their practices, and then they will gather the data on which are doing it, so we know at an LMC level, building a picture of nationwide, we can really get a good feel as to what's happening. Now, not every action will work in every single area because of locally commissioned services, because of various agreements that might be in place. But if it actually makes sense for the bigger picture, that's what we're going to be doing. And we've sought a lot of advice on what potential actions we could include. The committee has spent a half day looking at this matter completely. And I think things are starting to take shape, but they're not wholly and fully locked down. But we know, broadly speaking, what we're going to be doing in April. We probably have a pretty good idea what we're doing in May and June. And then things could start to ramp up. And that's where we'd need to also have our members determining our next steps. So this is what we're looking at. Everything depends on the outcome of the referendum. And if the referendum is a damp squib, then that makes the action all the more hard. Whereas, as I've been saying, this is extinction of general practice as a specialty. Now, if you want to be a 12-hour digital triage monkey, firefighting, primary medical services, and not providing safe or good care, then you do that. I want to be a GP. I was trained to be a GP. It is the greatest job. And if we're given the resources to enable us to do it, we can help make our communities thrive. But ultimately, our members are going to inform what, if any, actions that they want their trade union to direct, which will in turn inform our next steps. We're going to be member-led.
You said there, so you could be doing action from the 1st of April. It sounds like you've got a pretty good idea about what that might be. Are you able to say what that is or not at this stage?
I think it's important that the committee makes the ultimate decision, and our greatest weapon is surprise, and I don't want to release the details just too soon. I fully expect our actions of one action each time to be cumulative, so that you'll have some practices wanting to see what happens, and they might feel a bit more nervous and less inclined to join in. But then they might go, oh, actually, everyone's doing it. We will now too. And they can catch up and we'll get a bigger picture. And I think we're going to take an awful lot more inspiration from, do you remember I did a kind of kitchen video in June 2024 when we had wind that there were going to be sudden changes to GP Connect update record? And I basically said, this is really important, guys. I know it's Saturday morning. Please go into your surgery. Please switch off that button on the back end of GP Connect. This is really important. And over 90% of practices did within the space of 72 hours. That sent a huge message to NHS England and the Department of Health. And I think that's the sort of action we're looking at. Simple, deliverable, doesn't harm patients, isn't going to put partners at greater risk, but is absolutely going to get to the heart of trying to get the other side to come to the table, because that's what action is all about. It's all about a means to an end to get what you need. And what we need is a new contract.
So that'll start in April, and then you were saying in May and June. So you see like extra actions being added in May and June, and then by the time we get to that point, no movement from the government, that's when you might start looking at a statutory vote on maybe more extreme actions which would potentially put practices in breach of contract. Is that sort of the timeline?
Yes, it is. And that is LMC conference policy, but also will be very much informed by practices, by grassroots in the week ahead. But as I said, the biggest amount of feedback I get is around the unlimited, uncapped consultations.
Yeah.
And now the demands around urgent as well. I feel that just is not safe for practices. So we're also working on an OPAL framework, an operational pressures escalation level, where we could potentially embed it into System 1 or EMIS or Medicus to actually pull out what are the numbers per 1,000 patients contacting you. Actually, what are the safeguard measures that would tip you into amber, tip you into red, tip you into black? What could be sent to your system, to your trust chief execs and medical directors, automated emails going, this practice has hit this level, because then it's transparent, it's accountable, it is genuine that this is a patient safety concern. And we can quote so much patient safety evidence and regulation on a statutory basis that will demonstrate quite a lot of support for GPs taking these steps. And if one practice receives a breach, we know that all practices will have to receive a breach at a certain point. There is a timescale. We know it's going to get nasty. We saw a little taste of that in October and November. It will get worse, but ultimately, the consultant colleagues, the resident colleagues, they've had to take steps which have not been pleasant. They've had to go without pay when they're striking. This isn't going to be without some hard work on everyone's part. We've all got to stand together. Yes, they will try and pick us apart, but this is only going to get us somewhere if we act in a unified manner as a profession. That's why it will have to be on a statutory basis, but we're very much listening to what practices and GPs are telling us.
Statutory action is probably going to revolve around access requirements, around online consultations, potentially around the same day requirement that are in the GP contract.
I would not be surprised. The ultimate thing would be practice closures during core hours.
Right.
That's another option. But none of this needs to happen. All of it is about securing concessions, even if it's putting in place OPAL frameworks now to give practices a safe basis as to what's reasonable when they can mitigate overwhelm. Nothing is impossible. We are ready and willing to get round the table, to share solutions, to move things forward. This is not the space we want to be in. The fact we've been played with for a year does make us very frustrated, but we are still here wanting to do a deal and wanting to do business. And for shame on the government that it's trying to time us out, because we're not going to go away. The longer it goes on, the worse it's going to be in terms of the fallout for the government.
Last time you were on the podcast, we talked about certain elements on the GP committee being unhappy about your leadership. And in the past week or so, we've seen an LMC call for you to resign. What do you say to those people who think that the GP committee would benefit from a change in leadership now? Because this sounds like it is really a crunch point for general practice in England.
It's really interesting because I'm being criticised that I was too close to Wes Streeting and therefore I've got to go. And they're saying, now you've really upset Wes Streeting, you've got to go. Now, actually, I still have a positive, constructive relationship with Wes Streeting. I messaged him during GPC England to advise him what was going on. He messaged me straight back and apologised that we hadn't had a chance to get round the table. I've been messaged by Stephen Kinnock over the weekend and by the specialist advisors to government. It's a professional relationship. I've never been in their pocket because we went into action under a Labour government. People seem to forget that. And some of the things that have been put in the letter that you cite are factually inaccurate and they are lies. I am going to respond, but what's a priority for me was GPC England last week, and it's delivering the webinars this week, and I will respond to them, but that's going to be in my own time. The whole point of it was to try and get into my headspace ahead of GPC England. A lot of this is about individual egos and career ambitions and people who've had a go at trying to run the committee and haven't done it very well, and those people who might run GP services in ways that I don't want to defend. If you're running a bunch of APMS practices, you're not employing GPs, you're choosing to staff them with PAs and paramedics and make massive profits. I am not going to be your friend, and they know it, and they want me gone because I'm a risk to their business model. There's lots of vested interests. People are thinking about themselves and not the profession and the bigger picture. And I think if they don't believe that I am thinking of the bigger picture because they think I must think like them, why wouldn't I think like them? Well, they are not the kind of GPs that have my respect or support. I would like the opportunity to speak to their constituents and see what's your offer to your practices. Are you practicing what you preach? Are you working hard for your constituents? Are you being honest and transparent and living your life according to the Nolan principles as best you can? But again, all of this fighting is a distraction. Rather than fighting amongst ourselves, I'd much rather we're standing together and ensuring the government works with us to get a new GMS contract. Isn't that in everyone's better interest? To restore the long-term viability of partnerships, to get that fair remuneration for every GP and to get those workload safeguards that we need. That's what's the priority here. And so I have deliberately not allowed myself to get distracted by these bombs being thrown left, right and centre. You've got to focus on your job. They're just going to have to wait their turn to stand in a future election and show us how brilliant they are. And I very much look forward to them doing a much better job than me. I would love that.
So obviously the other thing that's trundling alongside all of these issues with the GP contract is this shift towards neighbourhoods. And we've seen so little information coming out of the government and NHS England about what all this means, what neighbourhoods should look like, the impact they'd like to have on practices. The BMA, you recently put out some guidance for a briefing note for GPs and practices with your views about what practices should be doing now. What do you think they should be doing now?
That was called Lead or Be Led. It's a bite-sized document. It's only 2 or 3 sides of A4. That was very much written from the heart. But equally, we were meant to have this guidance in the autumn, and then half term, and then November, then December, then after Christmas, then the New Year, then February, now Easter, and we're still waiting. It's this big flagship framework, but there's really nothing there. It feels like the emperor's new clothes, doesn't it? I think people are very nervous about making the wrong moves and the wrong decisions, but structures are being built. So you don't have to commit to anything, but you do need to be in those meetings engaging with those trusts, and it will be trusts. And if you have a large at-scale organisation, make sure you are happy with the governance there. If you're really unhappy with how that federation is run, well then take it over and make it run properly. Because the way I see it, we're probably going to see the PCN-DES merge into the single provider neighbourhood contract probably from next April, which means if they want to make any sweeping changes to the PCN-DES or locally commissioned services, they would need to give 6 months' notice. So that would be October going to April. You've got about 6 to 9 months to get your ducks in a row around your at-scale options. And if you haven't got any, then I suggest you do. Either your clinical directors or work with your LMC to make it happen. Remember that reinvestment in staff and services is going to be the way forwards. Think about how you could spend or use the outpatient budget or the diagnostics budget in a completely different way to deliver so much more funds for your system. And be part of those conversations. Don't risk any of your services. Don't share your data. Don't put your neck on the line. Just be present at the table having these conversations, because at the moment it is just hot air. But that doesn't mean to say you can't be there filling the knowledge vacuum because everyone wants to talk about general practice and primary care. None of them have a clue what it is you do, and you actually hold all the answers. So be engaged and be present in those conversations, but don't panic too much.
What's your sense about how neighbourhoods are going to shape up? Do you get the sense that primary care is going to be the place which leads this in most parts of the country, or do you think hospital trusts are going to be the ones in charge?
I think it's going to be a mixture,
Right.
Because you've got those areas where acutes are so in control that I think it'll be impossible for it to be anything else, especially in those areas where they are desperate to become integrated health
Yes.
organisations. And GPs should be working collaboratively across LMC footprints, across federations, across PCNs, to line up to ensure that these IHOs do not progress. They do pose a significant threat to partnerships. I think ICBs are going to be very unwilling to devolve budgets. I think acute and community trusts are actively blocking reform because they've got that intrinsic fear of a loss of their own income and contracts. Neighbourhood teams don't really know who's going to hold the authority. Where that sits with local government is really key, because if it's all going to be predicated around releasing bed days and ED blocks, well, then it's got to be tackling social care as well. So local authority and local government has got to be at the table. There's so much parallel lobbying and positioning going on rather than actual delivery planning. And so in that kind of space with no resource, there's not going to be any innovation. It's going to be people trying to lock in everything that they feel they currently have. That's why it's really important to try and get some sense of central outcomes and have those enforced consistently. Otherwise, it's a bit like the medium-term planning framework and advice and refer and these 22 cluster conversations around that being done. That is going to freeze us out of conversations, and it's going to feel very much more like vertical integration. And I think this is the problem. So think about your capability, budget devolutions, what's going to be mandated, what's going to be explicit, what's going to be protected, and some of the behaviours that you've got locally as well, how you're independent, how you can prove your financial transparency, because that will always be lobbied against us. And I think there's something here around prohibition of profit extraction that's going to be essential, because we're going to need to see confidence and faith in how stuff gets reinvested into patient services and protect the staff that we've got, because otherwise, if we don't have rules to follow, things are going to be really difficult. So that's why I'd love to see clear national guardrails that are outcome focused and applied consistently across places. I fear that it won't be. I fear it'll be far too woolly and far too enabling for those predator trusts and wannabe IHOs. We're in a very precarious time, and it's really concerning. So that's why I tried to put everything into a bit of a bite-sized bulletin for people to take with them to meetings and just remember all the things they need to remember, and look at your GP at scale organisations, and you've got 9 months to be making them work in the way that you want them to work. And don't wait for it to happen, make it happen.
You mentioned that IHOs were a threat to the partnership model. I mean, do you think neighbourhoods in general, do you still believe that they are a threat to the partnership model?
Neighbourhoods, if done right, are the answer to general practice in many ways.
Yes.
Giving us devolved budgets, a bit like with practice-based commissioning and GP fund holding before them, put an awful lot more into general practice in the driving seat. But if done badly, then yeah, at worst, it's vertical integration. And with integrated health organisations, they will also have the ability to do their own local contracts, consultant contracts, resident contracts, staff and associate specialist contracts. So that's the importance of mobilising other branches of practice and understanding that is a potential death knell to your national contract and terms and conditions. Now, what would it mean to performance management of the partnerships in that area? I think there's a lot to learn from North East and North Cumbria system, where Northumbria primary care, I think there's a vertical integration pattern. And of course, that is Sir Jim Mackey's old patch. Much to learn from there, often cited as a really good working example. But actually, if you look under the bonnet of how that has been commissioned, how it is governed, how it is structured, I think it's far from the ideal that most partners would outline that they want to see. So I think we can look and learn from examples, but that's why it's so important that GPs are at the table and in these conversations.
You're running a series of webinars, aren't you? Do you want to just tell everybody when they are? I think the first one will probably be happening almost immediately after this podcast comes out. So when are they all happening?
Yes. Thursday lunchtime is the first one. I think it's 12 till 1:30. And the next week is Tuesday evening. And the week after is Wednesday lunchtime. So we've tried to go Tuesday, Wednesday and Thursday. So there's different days for different people depending on their clinical duties. You need to be a BMA member to vote in the referendum. And no, there isn't any new free offer to join the BMA right now. So if you're a member, make sure you use your voice and remind everyone to vote. It's going to be dead easy. You're going to get an email from an address that is like at cesvotes.com. It's from Civica. They independently run the referendum. Back in March 2024, we had over 19,000 GPs vote and we secured an insane mandate. I would love to see the same thing because I think we really have got no further forwards. In so many ways, everything feels tone deaf and going in the wrong direction, which is not good for the NHS, not good for our patients, awful for us and our individual careers as GPs as well. But also we're thinking about what about our families and our friends and ourselves when we get unwell. I think all of us are starting to get increasingly spooked by what's going to happen. So this really is fighting the good fight and you've got to be on the team.
Thank you very much for your time, Katie. I really appreciate it. It's been great to talk to you again.
Thank you, Emma. I really appreciate it too.
Well, that's it for this week. Thanks so much for listening and thanks again to Katie. I'll be back next week when I'm talking to some more BMA GP leaders. I'm speaking to the co-chairs of the BMA Sessional GP Committee, Dr Amy Small and Dr Kim Rollinson, about the challenges facing salaried and locum GPs, what needs to happen to address the jobs crisis, and what the BMA is doing to support and represent sessional doctors. So please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and the latest on the GP contract at GPonline.com.